This session will start quickly without any break. This session will be a kind of debate session. State of ART, infertility treatment. Should it be disease-specific or patient-specific? Our first lecturer will be Professor Ying Cheong from UK, and she will try to prove, at least, the infertility management should be disease-specific. She is the professor in reproductive medicine in the University of Southampton. She is also the director and the founder of the Complete Fertility Center Southampton at the Princess Anne Hospital since 2011. Please, Professor Ying Cheong.
Thank you, Chairman. Good morning, ladies and gentlemen. Now, I want to convince you that management should be disease-specific. Let me tell you why. First of all, let's start with the definition of medicine. As the Oxford Dictionary states, it's a science or practice of the diagnosis, treatment, and prevention of disease. Disease is what I like to emphasize. You see, when treatment is not disease-specific, we cannot practice proper medicine. We resort to guessing. I like to share with you a little rhyme. Starts like that. Eeny, meeny, miny, mo. Pick a treatment, give it a go. Instead, be bold and say no. As there are some things where we just don't know. Eeny, meeny, miny, mo. You see, when we don't have a disease-specific treatment or management, we resort to a treatment for everything. Like, as you can see here on Time magazine, for Botox. Well, depression, heart trouble, migraines, erectile dysfunction, back pain, sweaty palms, drooling, and 793 other conditions proposed as a suitable form of treatment. Let me talk you through the ABCs of disease-specific management. It has to be accurate and precise, based on evidence, and credible. So treatment needs to be disease-specific in order to satisfy these ABCs. Let me show you why. Well, we're all here because we practice IVF. And in fact, the invention of IVF is based on our knowledge on fertility and infertility. Tubal disease, well, there's no way the sperm is going to ever meet the egg. Well, IVF solves the problem. Without it, we're all not going to be here. ICSI, well, the sperm is not going to fertilize the egg. But here we have an understanding of the science and what we're treating, and therefore it was successful. And again, we all practice ICSI nowadays. Accurate and precise. We are now into the era of high throughput sequencing. You heard this morning, beautiful lecture on how genetics will transform our practice. Let me talk you through and show you, in terms of endometrial receptivity, why disease-specific management is important. Well, the very three questions we often ask. Can genetics help us predict the window of implantation? Can we then manipulate this window and enhance implantation? The last and not least, the most important question, solve the problem of this issue around recurrent implantation failure. Well, just to give you a summary, and really not in detail, but you can see that genetics is not an easy avenue to resolve. It involves transcription, translation, post-translation events, and of course, in addition to that, recent data around how exosomes and extracellular events also gets involved and entangled in this whole genetics study and how these processes are being translated. And if you look at the number of studies that are out there looking at this area, you can see in terms of endometrial receptivity that transcriptomic studies have escalated over time. But in fact, when you look at the meta-analysis, there is unfortunately not a lot of consensus. And in fact, also, many of the implantation factors are not even highlighted in these studies. A good colleague of mine, his group in Utrecht, published this not too long ago in Scientific Reports, very encouraging 303 genes, predictive of the recurrent implantation group. But of course, this is an early stage that requires validation. And time again in these studies, where eventually it goes out to a general population, that's when things fall down. Those of you who were here yesterday would have heard a brilliant lecture by Carlos Simon, and of course the area around endometrial receptivity testing. And you know, based on NGS technology, they identified over 200 genes. You take a biopsy cycle before, and then it will tell you whether the endometrium is receptive or not, and how delayed it is. But of course, we're waiting still for the RCT results. And of course, in my mind, the question is, histological dating, is it the same as just doing the ERA? Is it equivalent to histological testing? These are questions that are yet unanswered. But in fact, if you look at this brilliant technology that's been developed over the last 15 years by the genomics group, you see that even at the best hands, 25% potentially we will diagnose the problem with implantation window. But what about the other 75%? The other question I like to ask, pertaining to the question of disease-specific management, is can we predict the window of implantation? Now, by the way, what is recurrent implantation failure? If you look at the definitions and options of definitions, as listed here in 1, 2, and 3, they could be defined as cycle failed varying between 2, 3 cycles or more, fresh, frozen cycles, plus, minus any of those permutations. It could be defined by embryos transferred varying in numbers, depending on the definition the group takes or the paper takes. The stage, the quality, whether it's fresh or frozen. And of course, it can also be taken as a combination of unsuccessful treatment cycles, plus minus the embryos and the quality and the stage and the number. So there are more than 50 permutations of this definition. Are we even talking about the same thing? What is the disease? So the question that I asked earlier, can it predict implantation window? Can we manipulate this window? Can we solve the problem of recurrent implantation failure? Well, ladies and gentlemen, the answer will always be vague and inconsistent because we lack a disease-specific understanding and therefore a disease-specific treatment. Next, B, based on evidence. Well, of course, things have to be based on evidence. Otherwise, we'll be practicing bogus medicine. And the level of evidence, ladies and gentlemen, can vary from the best of the best, which is systematic review, to, of course, controlled studies, as long as the studies are well conducted. But some studies have to be done, and good quality studies, in order to support our practice. I'm sure you all agree. For example, in the case of, does hydrosalpingo affect pregnancy outcomes? Well, you can see from retrospective studies, these are only retrospective studies, that actually live birth is influenced and it's decreased by this. And furthermore, with randomized controlled trials, and this is Cochrane systematic review, the recommendation, therefore, is clear that removing the hydrosalpinx will influence and benefit the outcome of IVF. Very clear evidence-based, disease-specific management. Now, when disease-specific management is not being followed, it can lead to unjustified add-ons. This is a study published in BMJ about what evidence there is in the interventions we have in the UK. And in fact, you can look at the bottom box and it shows all this treatment that we currently offer and charge our patients. These are called add-ons. Is it ethical? Is it ethical when we don't have yet got the evidence? Now, we also know, and there have been a number of recommendations on immunological testing, that actually we're still unclear about its value. But yet, this paper has shown that there is a widespread use of this testing in order to find out an answer for our patients. And many times, of course, the answer is unclear. We don't know which direction of treatment. We had that good discussion this morning about it. But you see, non-disease-based treatment is irrationally infectious. One team is doing it, the other team will catch on and do it, and everybody else is doing it. Just like the story with the scratch. Cindy Farquhar's group published this not too long ago in Human Reproduction, a survey on who's doing the scratch, and of course, everybody is doing it. The thing, though, is if you look at the bottom table, table 1, non-disease-specific treatment leads to confusion. Why? Well, in the question about what do you use it for, you can see there's a variation of answers. Recurrent implantation failure, unexplained infertility, endometriosis, advanced age, recurrent miscarriage, polycystic ovarian disease, and another last column. I offer or recommend endometrial scratching to all women having IVF ICSI. What are we treating there? Everybody? Are we turning this story into the Botox Time magazine I showed you earlier? Credibility, C. Management must be disease-specific. And if you look at these guidelines, we can make guidelines so that everybody can look at it, at the evidence-based recommendation and follow it with credibility. But if we don't, there is a danger. There's a danger of loss of confidence with our colleagues in the medical field, with our colleagues in our own specialty, with the public, and with the press. We do not want our patients to say this, surely, but loss of credibility will facilitate this and encourage it. We really don't want that. So, when treatment is disease-specific, we no longer need to resort to guessing, ladies and gentlemen. And I will end with another little rhyme. Eeny, meeny, miny, mo. Find a treatment, in time we will. That's based on science. What a thrill. Because as doctors, we must show our worth from conception right through to birth. In the future, when we rightly know, there's no need for eeny, meeny, miny, mo. So in conclusion, ladies and gentlemen, of course, treatment can be personalized, but management should be disease-specific. Thank you.
Thank you, Ian. We will have the discussion at the end, please.
Now we will move to the second speaker. First, I would like to give some brief information regarding Dr. Kübra Boynukalın. She is a graduate of Hacettepe University School of Medicine and obtained his specialty degree at the same school. And afterwards, in 2013, she obtained the master degree in biotechnology of Human Reproduction in International University of Valencia. In her past academic career, she contributed several clinical and laboratory research and appeared as the first author and co-author in several national and international publications. And her current position is she's a member and IVF consultant in Bahçeci Group. The stage is yours.
Thank you very much. Dear my colleagues, first of all, I want to tell my pleasure to be a part of this lecture with my great, skilled, lovely friend, Dr. Cheong. I hope it will be a good interview. First, I want to explain what is disease, what is pathology. A disease is an abnormal condition, a disorder of a structure or function that affects part or all of an organism. The study of disease is called pathology. In disease, only the local part or system may be affected, but as its result, patient suffers as a whole. Disease evolves as a phenomenon. Each patient suffers differently, and patients have different tendencies, as we all know. We are all scientists, and we seek for accurate data which we can form solid treatment recommendations with regard to our patients. Evidence-based data seems to be the most useful tool for the same. Evidence-based approach focuses on using RCTs to establish the best treatment for the average patient and ignores the outliers. However, we should consider evidence-based data if they are disease-oriented or patient-oriented. Disease-oriented outcomes suffers histopathological, physiological, and biomarker differences, whereas patient-oriented outcomes suffers morbidity, mortality, difference in symptoms, and quality of life. Medical literature is full of examples of studies that relate disease-oriented evidence. These studies illuminate the etiology, prevalence, and pathophysiology of disease. They give us insight into the disease process. It is the basic of medicine, but are less helpful in the clinical management of patients. Patient-oriented evidence suffers basically long-term effects of treatments. In fact, many studies' preliminary data were promising or intermediate results looked good in patient-oriented evidence, but when real patients and outcomes were measured, results were disappointing or even showed the intervention to be unsafe. An example of disease-oriented evidence and patient-oriented evidence in homocysteine levels and cardiovascular disease risk. Disease-oriented evidence suggests the use of B vitamins and folic acid supplements lowers homocysteine levels. Since homocysteine is an independent predictor of the risk of developing cardiovascular disease, practitioners should logically come to the conclusion that using these supplements will prevent or treat cardiovascular disease. However, the HOPE trial showed that there was no difference in the combined risk of cardiovascular death, myocardial infarction, or stroke between the groups who used B and folic acid and those who did not. So patients may spend money for preparations that do lower a number on lab tests, but ultimately make no difference in their risk or heart disease. Most similar example like this in ART is dehydroepiandrosterone usage as an adjuvant for poor ovarian response. First case series focused on the controlled ovarian hyperstimulation parameters and reported higher A2 levels, higher number of oocytes retrieved. Dehydroepiandrosterone is now widely used in poor responders. A recent worldwide survey showed that 25% of IVF clinicians add dehydroepiandrosterone as an adjuvant to IVF treatment protocols in women with poor ovarian response. Most recent publications argued that dehydroepiandrosterone is not a totally benign drug, and that treatment may cause possible androgenic side effects, including acne, deepening of voice, and facial hair growth. And also, latest Cochrane review reported that it has no enhanced effect on clinical pregnancy rates compared to placebo. Lack of harm should be considered as an argument to support dihydroepiandrosterone treatment. Let's take a look at the management of endometriosis in infertile patients. It should be disease-specific or patient-specific. As we all know, endometriosis is a chronic inflammatory disease that may affect fertility. The prevalence of the disease in infertile women is 25 to 40%, tenfold higher than in general population. However, infertility is not pathognomonic for endometriosis, and substantial proportion of affected women can conceive naturally. In a recent study, it was reported that a cumulative chance of pregnancy was approximately 40% in unoperated women with an ultrasonographic diagnosis of endometrioma at 6 months. The pathogenic mechanism linking endometriosis to infertility are still controversial. The 3 different forms of endometriosis may differently affect conception. Most of the clinicians concerned about the management of infertility patients should be surgery or IVF. If endometriosis causes infertility, it is easy to say that its surgical removal should improve fertility. This view is now more and more questioned because of the modus effectiveness of surgery. There are three main reasons that disappoint the removal of lesions. Removal of lesions cannot reestablish normal anatomy and physiology. There is risk of recurrence and also unacceptable risk of surgical complication should be considered. There is a strong rationale to support IVF use in endometriosis. The procedure may overcome most of the detrimental effects of the disease. However, endometriosis was not shown to be associated with higher chances of pregnancy when compared with other indications. Worst, the recent meta-analyses tend to support a detrimental effect in severe cases, but evidence is not definitive. An increased risk of disease progression, long-term malignant transformation, and pelvic infection during IVF procedure is the most relevant concerns about IVF treatment in patients with endometriosis. In the decision-making process, some factors require particular attention. Younger age, presence of severe pain, the documentation of clinically significant stenosis of ureter or intestine, the presence of large endometriomas, and ultrasonographic findings suspected malignancy should favor surgery. Conversely, IVF should be considered first women who have already been operated, for those with bilateral endometriomas, and for those with adenomyosis. The diagnosis of a concomitant male factor of infertility or a reduced ovarian reserve should also favor IVF. We should be patient-specific for the management of endometriosis. My colleague Cheong reported a meta-analysis that reports the impact of endometrioma on IVF outcomes in 2015. Let's take a look at the conclusion of this abstract. Women with endometrioma undergoing IVF had similar reproductive outcomes compared with those without the disease, although their cycle cancellation rate was significantly higher. Surgical treatment of endometrioma did not alter the outcome of IVF treatment compared with those who did not receive surgical intervention. Considering that reduced ovarian reserve may be attributed to the presence of endometrioma per se and the potential detrimental impact from surgical intervention. Individualization of care for women with endometrioma prior to IVF may help to optimize their IVF results. Second issue, polycystic ovary. Polycystic ovary syndrome is the most common endocrine disorder in women of reproductive age. Rotterdam Consensus concluded that diagnosis of polycystic ovary should be based on at least 2 of 3 major criteria, including oligoanovulation, clinical or biochemical signs of hyperandrogenemia, and polycystic ovaries as identified by ultrasonography, also excluding other androgen excess disorders. However, Androgen Excess Society reported polycystic ovary syndrome is primarily a hyperandrogenic disorder, and clinical or biochemical hyperandrogenism is a must for the diagnosis. It means that anovulation is not a mandatory criteria for both of them. As we all know, we have 4 different phenotypes for polycystic ovary syndrome. All phenotypes should be managed the same. It should be disease-specific or patient-specific. Approximately 60% of women suffer from anovulatory infertility have polycystic ovary syndrome. In 2016, WHI reported a guideline. A part of these patients have regular ovulation. Although the patient have regular ovulation, fertility is adversely affected by individual being overweight, having hyperandrogenemia. Lifestyle intervention is recommended first in women who are obese. Bariatric surgery can be considered where BMI is greater than 35 and lifestyle therapy has failed. CC should be the first-line pharmacotherapy for ovulation induction, and letrozole can also be used as first-line therapy. Metformin alone has limited benefits for the treatment of infertility in polycystic ovary syndrome. But it should be a part of treatment for patients with impaired glucose tolerance. Gonadotropins and laparoscopic surgery can be used as a second-line treatment option. IVF can be used with the safer gonadotropin antagonist protocols for the patients who did not suffer from other treatment options. As a result, we cannot manage all phenotype of polycystic ovary syndrome the same. We should consider not only the phenotype, but also the BMI, age, and other medical conditions before deciding the management. The treatment should be patient-specific. Another issue, uterine fibroids. As we all know, uterine fibroids are the most common form of benign uterine tumors. It's the pathology. As all pathology does not cause a disease, it most commonly does not cause a disease. Many fibroids are asymptomatic, but almost 1/3 of cases, they show a variety of symptoms depending on the location and size. Fibroids can cause heavy menstrual bleeding and anemia. Large fibroids can also result in pressure symptoms, urgency, urinary frequency, and urinary incontinence. Published reports of the effect of fibroids on the reproductive outcome and fertility may be confusing. Submucosal myomas are strongly associated with poor fertility outcome and should be removed in the settling of infertility. While intramural myomas have also been associated with poor fertility outcomes, the data are not as strong as submucous fibroids, and thus future research is necessary in this issue. Not only the size or location of myomas, the presence of anemia and surgeon skills and facilities can differ the treatment options. In the majority of cases, hysteroscopic myomectomy for type 1 myomas is relatively straightforward for experienced surgeons. If a fibroid is type 1 but larger than 3 centimeters, if the patient presents with anemia, prehysteroscopic medical treatment should be indicated. Symptomatic uterine fibroids require surgical or medical therapy according to the severity of symptoms, age, infertility, wish to preserve the uterus, and FIGO classification. The decision process should be the patient-specific. And in conclusion, various developments, personalized medicine make a shift from population-centered to individual-centered approach for prediction and prevention of disease. Not only the prediction and prevention, but also targeted treatment strategies are adapted successfully to modern medicine. Patient-specific therapy implies a therapeutic product that is unique and specific for each patient. Every disease alters in different bodies, and treatment should be patient-specific. And also, I want to remind you that every woman is special. Thank you for your attention.
Thank you so much. Any questions from the audience? Okay, I have a question for you, Ying. And let's say we have a patient at 36 years of age, and she has consistently a case of poor oocyte quality. She had 4 cycles up to now, IVF cycles, and at the end of 4 cycles, she only had 7 weeks of loss, 7 weeks missed abortion, pregnancy loss. And what do you suggest? Is this a disease-specific case or patient-specific case? And what do you do in your practice for such a patient?
So if I get your question right, so this lady, what age is she?
36,
36.
With an AMH level of 1.8
Low AMH, low reserve,
nanograms per ml.
low oocyte number on stimulation, 4 cycles, eventually successful, and she suffered a miscarriage.
Yeah.
Yeah. So is it disease-specific or is it patient-specific? Well, this is a case where it's very common. We see it all the time. And the issue here, Chairman, is that we actually can't put our finger on what the disease pathology is. The specific science behind the whole area of low reserve and so on and so forth in a younger patient is not quite known fully. We have some studies showing perhaps the genetic contribution, mutations and so on, but the story is not yet complete. So in order to say she has a disease, we'll have to understand this. But I deeply believe, given that this is my side of the argument, that we, if we knew the disease behind her condition, i.e. the exactness of why this had happened to her, we would be able to intervene in a much more effective way. And hence, at this juncture, given that we don't have a clear scientific understanding, we resort to managing the patient's expectations, we resort to managing symptoms, not a patient alone, also her partner. Every woman's special, every man's special too. And therefore, I suppose in this case, it's about managing the couple expectations rather than specifically saying, I can treat you by doing X, Y, and Z, which I showed you in my presentation. In the absence of a specific disease, we end up guessing.
Kübra, do you have any comments?
I think that there is some difference with the pathology and disease, and also your questions about this. The implantation, for example, implantation is a pathology or a disease. We do not know exactly. For example, receptivity. it is a normal of variant or it is a pathology. We do not exactly know this also. The personalization is important at this view. We should also suffer the differences between pathology, variance, and normal variance of normal and disease exactly. In this view, we will be more clear about the patient's treatment options.
Okay, thank you. Any questions? Any comments? En arkaya mikrofonsa, evet.
Thank you for the presentations. I have a question about bilateral endometriomas for Ms. Boynukalın, because we do not prefer to use surgery in patients with bilateral endometrioma. However, in practical clinic, we sometimes see really poor oocyte quality and fertilization failure in patients who have bilateral endometrioma. In these patients, do you prefer to surgery after the first failed fertilization or poor oocyte quality?
I can't hear the question.
For the second speaker, I have the...
We can't hear the question. We
You-
can't
We
hear
cannot exactly hear your
question.
what is.
Can you repeat your question? Sorry.
In patients with bilateral endometrioma, we do not prefer surgery for the first time. However, when we do prefer IVF, we can see poor oocyte quality and sometimes failed fertilization. What's your opinion about these circumstances?
We do not prefer to make surgery for the for patients with bilateral endometrioma, because we have some desire about ovarian reserve of the patient. We prefer to aspirate the endometriomas and perform the IVF after the procedure.
However, when you encounter after the IVF poor oocyte quality and failed fertilization for the second time, do you prefer surgery or IVF?
We do not perform. Also, in this situation, we do not perform operation because we know that endometrioma and oocyte quality is a very controversial issue. But in 2014, Philip reported reported a paper, and in this paper, the quality of oocytes did not differ in affected ovary and non-affected ovary. So that I think that, the operation will not have any improving effect on the quality of embryo and oocytes.
However,
That's an interesting question, and again, it's something we face all the time. Do you remove the endometrioma beforehand or not? As my other speaker has said, it's controversial data. However, I think in practice, it depends on the size of the endometrioma, because if it's rather large, I don't think we have an option. It is, however, important to assess the ovarian reserve beforehand, because as you know, surgery can destroy the ovarian reserve. But in addition to your question on oocyte quality, we've done some work and published it, I think, early this year on how endometriosis patients with follicular fluid extracted from them, and then we culture it with oocytes. We see that actually DNA damage is increased in patients with endometriosis. So the field is divided at the moment. There are people who believe that indeed that endometriosis should be treated as early as possible, because it does, in the long run, have impact on the oocyte DNA damage and quality. And then there is another camp that believe that, don't do it until when it's needed. My personal view is, if patients come to me with reasonable reserve but have bilateral endometrioma or unilateral that is maybe about more than 3 centimeters, I would remove. remove. But of course, the surgical technique has to be assessed and not you over-diatomize, so that you don't lose a significant amount of oocytes. If you do encounter really small endometriomas in a normal surgery, for example, if they're tiny, I would not do a cystectomy. I would do an ablation because you aspirate and you do an ablation rather than cystectomy so that you don't lose the ovarian reserve.
It's a very specific issue, really, because, for example, I have some patients. Really, first I try to freeze the embryos because I scheduled an operation after the IVF. However, in some specific group of patients, not all patients, really the oocyte quality is really low, poor. Maybe because of iron accumulation in the endometrium, I don't know, but really there is a little group of patients who really have really poor oocyte quality and may benefit from surgery.
Yes, yeah, I
Okay.
agree. Yeah.
Thank you. Any more questions? Okay.
I have a question for both lecturers. In your opinion, do the IVF practitioners in the field perform disease-specific management or, the other option, patient-specific? And what % do you think?
I think that most of the clinicians prefer to consider patient-specific. Because in our general practice, we do not only cause about the disease, we cause about the sufferers of the patients and other conditions. But I think that most of the doctors think like patient-specific, not disease-specific.
I do like to make a conclusive statement, if I may. Whilst my topic is disease-specific and I was warned not to go into a fight with my opponent, I do think in our practice we have to be holistic in terms of approach. So in other words, whilst there's a disease, would be ideal, but when we're treating a condition, is actually a patient that we're treating. So I think it's important that we don't lose sight of the fact that it's a human being that we were talking about. They have different expectations, they have different needs. And so I think it's important, whilst we need to understand the presence or absence of disease-specific management, we've got to remember that it's the patient that we're dealing with.
Thank you. Okay, I'll have some housekeeping notes. We will have a coffee break now, and we need to start at 10:30 a.m. sharp. Also, we will have a lunch satellite symposium at 12 p.m. Medical management of endometriosis. So let's see there. Bye-bye. Thank you.